Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School in Duluth. I'm also a family doc at Gateway Family Health Clinic in Moose Lake. I am your host for our program tonight on men's health, prostate, kidney, and bladder problems. Remember, the success of this program is very dependent on you, the viewer, so please call in your questions tonight or send them in ahead of time to our email address, ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Rebecca Beach, a urologist with Aspirus at St. Luke's Clinic, Dr. Nathan Hoffman, a urologist with Essentia Health, and Dr. Addie Vittorio, a family medicine physician with Aspirus St. Luke's Clinic. Our medical students answering the phones tonight are Riley Berg from Bemidji, Minnesota, Alex Higgins from Stewartville, Minnesota, and Wyatt Windhorst from Alexandria, Minnesota. And now, on to tonight's program on men's health, prostate, kidney, and bladder problems. Dr. Vittorio, welcome back.
Thanks.
You were just here last week. Good to see you. You want to tell us a little bit about your practice?
Yeah, I've been in practice 15 years, and it's all been with Aspirus St. Luke's. I've wandered around from clinic to clinic. I see a full spectrum of outpatient practice, so that means I see people in the office only. I do see primarily women, but I will tell you that women have spouses, and I see a lot of men, as well, at the urging of their spouses. So
That's usually how they get in.
Yeah, exactly.
Dr. Hoffman?
I'm a urologist at St. Luke's, seeing basically the gamut of anything urologic. So a lot of prostate issues, bladder issues, kidney issues, as were previously discussed. See lots of different types of cancer, see different types of urination issues. So just a broad range of what we would call general urology.
Dr. Beach?
I'm also a urologist at Aspirus St. Luke's, and I see full spectrum adult urology with men and women's bladder, kidney cancers, prostate cancers, as well as benign things like urinary incontinence and stones as well.
So, Addie, just because you have these men coming to see you, let's talk a little bit about men's health, because that's part of this show tonight. What kind of things do you do for a male that comes in? Pick your age group if you want to work with them in their health and make them better.
yeah, and I will tell you, do we see men in their 20s and 30s? Yes, but it's typically for acute issues. There's not a lot of men in their 20s coming in for a physical at that point. They're usually having an issue, or we're talking about STD prevention testing, or not, doing dumb things to harm yourself at that point. So the men I see who are in the 30 to 75-year-old range come in for physicals, come in for visits, and I say, whoa, your blood pressure looks really high. We've got to start working on some stuff. Can we check your labs? And along with that, what do? Well, we check blood pressure. That's a screening test. We look at cholesterol values and the risk of heart disease. We make sure shots are up to date. We check things like a PSA when indicated, and I'm sure we'll talk about that in a little bit. And then we, do the typical things we do with the countersex, which is colonoscopies and immunizations, and then talking about risk stratification. So what that means is, what is going to be your biggest health risk at that point in your life? And so as men age, we know that heart disease and cancer kind of become bigger issues.
That's great. And how do we get more men to come in and do that is the next question.
Well, my biggest thing is if you have health insurance, come in for your annual visit. Use it. Use that very low copay or often free visit as a chance to talk to your doctor and troubleshoot and really figure out, am I missing something? Am I covering something I need to? Am I doing all I can to stay healthy in the future?
So Nathan, tell us about the prostate.
So in terms of the prostate, it's a joke that it helps you have kids when you're younger, and then it helps to keep me employed when you're older, because it actually does not have that much of a physiologic function much past your 30s, but it does tend to cause problems. It gives you cancer, it gives you issues with urination, and so that's generally what we see people for. We don't actually see a lot of general health, and I'm guessing Dr. Beach either. We do see a lot of people for as I said, urination issues, prostate cancer screening, specifically the PSA, which has been poo-pooed over the last few years, but is still an excellent screening tool that we think is still does a great job of screening people for prostate cancer. And we also see people acutely for kidney stones, and then we work on kidney stone prevention in terms of their health and their diet and making some medication changes sometimes as well.
Dr. Beach, maybe give us a little background on the bladder and kidneys too. That's all part of our charge tonight.
Yeah,
so.
of course. I think that, there's a few things that I think that everybody should know are reasons to see your doctor. If you ever have blood in your urine for any reason, if you can see blood in your urine, you should be seen by your doctor. It always should be evaluated. I think if you're having troubles with recurrent infections or things like that, or if you're having, leakage of urine, which tends to be more like a quality of life issue, but it can still, there's still many things that we can do to help make things better and improve your quality of life as well.
Very good. The questions are going right to prostate, and we kind of suspect that
Yeah.
they might do that. The first question I have is, what can I do to prevent prostate cancer, and are there any screening recommendations? So you kind of lit into that a little bit.
Yeah, I mean, there was, as I said, a time when PSAs kind of got poo-pooed, but there are many cancers that would love to have a test that is as quote-unquote flawed as PSAs. It's still an excellent screening tool. Yes, a PSA that's elevated does not always mean cancer, but it means that one of us should get involved in that story. And in general, the things that are heart healthy that you've heard for years, keeping your blood pressure low, exercising, eating right, is in general considered prostate cancer healthy as well. So the things you've heard for years to take care of yourself generally takes care of your prostate too.
When should a man start having his PSA checked?
I would say that really depends on family history. We know that prostate cancers can run in families. So for patients that have a first-degree relative, so a brother or their dad that has prostate cancer, they should probably start screening a little bit earlier. I usually start screening those patients I usually do a baseline about 40, and if it's less than 1, then I do another one at 45, and then I start, usually annual screening about age 50 to 55, depending again on their risk factors. The average patient I still think should maybe have a baseline PSA at 40, and if that's less than 1, then I start really doing screening about 50 to 55 annually, and I usually stop screening about age 70, but it really just depends on what other health issues they have as well.
Yeah. And this can vary between practitioners because a lot of primary doctors will screen with a PSA every 3 to 5 years, based on some literature. Yeah. So it's really a conversation you need to have with your doctor about what your risk factors are and what your comfort is with the level of screening you're getting.
So as a family doc, what about rectal exams?
Well, I can tell you that our older docs who kind of trained in the 80s and 90s still do rectal exams and PSAs together. What rectal exams actually pick up are anatomical abnormalities of the prostate. In my training in the 2000s, we were taught that wasn't very specific and it wasn't absolutely necessary as a screening tool. But that doesn't mean that when you come into your doctor and you say, I'm waking up 6 times a night to pee, or I'm having trouble emptying my urine, that you don't need a prostate exam. Those are reasons where you need a doctor to examine you in that area and do the rectal exam.
I think the thing to remember is that there's not one size fits all, pun intended, for prostate issues. People's prostate size varies, their PSA levels vary, their family history varies, all that stuff. And that as practitioners, we all build that into how we screen people. And so people who come in with like an absolute hard and fast rule is not always what's needed. But again, the cutoffs are 40s if you have a family history, and then 50s if you're asymptomatic and normal without a family history.
Rebecca, what are the best treatments for BPH?
That is, again, another very nuanced question, but for most patients that present to me with BPH symptoms or having difficulty emptying their bladder, I usually start with medications. Usually I start with medication like Flomax or tamsulosin. It's a medication, it's usually pretty well tolerated. You take it once a day. Sometimes it's cheap, yeah. I mean, it's been around forever. There are other medications that can help. Something called finasteride that can help shrink the prostate, but that's not for everyone. That tends to have some other side effects that we would talk about, but I do use it pretty often. And then there's a number of surgical options for helping with BPH. And really depending on the age of the patient, their overall health, what their sexual activity is or sexual expectations are, that all goes into determining what is maybe a surgical option that might be helpful for them.
The goals of longevity, how long they want the treatment to last and how much they want to do to get it to last that long, is generally the process by which you select them. The more invasive, the longer they last, but the more side effects you have,
Right.
is
And
the general rule.
It used to be like we wanted to do one procedure that was going to make it so they never had to be treated again for their BPH symptoms. And now we have less invasive things that might get them 5 to 10 years without taking medications, have less sexual side effects when they're younger. But then, when they're a little bit further along, or depending on their anatomy, then we might do something a little bit more aggressive. So now I feel like we're approaching it surgically more in a staged fashion instead
Right.
of being a one and done type of situation.
Right. The surgeries were dangerous, and so therefore you didn't want to do it more than once. But now we've got such easy things that we can do. We can say, all right, this is going to get you through your 50s when you tend to be more sexually active and want the fewest sexual side effects and the fewest time off of work. A lot of them have time off work, but then you're in your 70s, the sexual interest is generally less, not always. But then also in your 70s, you can have more time and you can go through a little bit more to have it be kind of more of a longer lasting procedure.
You kind of bring back memories of the 70s. I'm the oldest one here.
Yeah.
And a gentleman surgeon who used to work at Essentia who would take a few chips every so often. He never rendered anyone incontinent, and it worked really well on a periodic basis just to go ahead and open up.
Yeah.
Addie, what can be done to prevent BPH?
A lot of that is genetic or hormonally influenced. So, if your father had issues with BPH or your brother does, you are very likely to start having issues, around the same time frame. We do want men to be physically active and live a healthy life and, not smoke, not drink excessively. All those things affect different aspects of how the urine drains, in addition to the prostate. So if you have issues where you have an alcohol problem, we will see urinary retention because of some of the neuroreceptors that are kind of in the area. So it's not the BPH, but it's other factors affecting that as well.
This person's already had a Euro lift, and that's new, and I thought I knew what it was, but I don't remember, so you're going to tell us. And he's on Flomax, but still have to take, or still have trouble initiating urination. A weak stream, what else can be done?
Well, unfortunately, the UroLift is another way to, basically all these procedures that we've been talking about open up the hole in the prostate wider to allow urine flow better. So that is one potential issue as to why someone can't initiate their stream. The other one is the bladder actually has to push the urine out. And so we're really good at making the hole in the prostate wider. We're not as good at telling the bladder what to do and actually squeeze harder. So it would depend on, but like we said before, the UroLift is one of the ones that's one of the more lesser invasive procedures that doesn't tend to last as long. And so as a result, this person may need to have someone evaluate them to look at, do they need to go to one of the more aggressive procedures to try to open them up even more aggressively, or is it just a situation where the bladder can't squeeze hard enough, in which case that's a little bit trickier to fix.
Prostate cancer. Take us down that road a little bit.
Sure. So prostate cancer is a very common cancer in men. It affects about 1/3 of men in this country. And the big thing about prostate cancer is it can be either very benign or it can be very aggressive. And it really, every man's prostate cancer story can be very different. So typically patients are diagnosed with prostate cancer based on their PSA or an abnormal exam. And then based on that, we do a biopsy. The biopsy will tell us how aggressive the prostate cancer is and what we should do to treat it. So if they have something like Gleason 6 prostate cancer, which is the lowest risk prostate cancer, most of the time we will do something called active surveillance, or we won't actually treat them, but we'll monitor them to make sure it does not become something that we need to be more worried about. Then there's intermediate risk prostate cancer. So those are the guys that we usually recommend treatment for, either with surgery or radiation. And then there's the high-risk prostate cancers that we usually recommend, treatment if it hasn't spread, then still with surgery and radiation. But sometimes if it's already spread to other parts of the body, then we need to think about chemotherapy, hormone therapy, other multimodal treatments to help treat or cure that prostate cancer.
Nathan, this is probably for you or either one of you. Are there treatments for cancer that spare the ability for sexual activity?
Yeah, I mean, in radiation and in surgery both, ejaculatory preservation is very difficult, but erection preservation is generally fairly easy to achieve. And so it depends on what you define as sexual function. Ejaculatory preservation, in general, anytime you mess with the prostate in an aggressive way, either radiation or surgery, that will be difficult. But erection preservation, we have many, many tools to get erections back. Anywhere from just medications that you take as pill form, you can do injections of medication, and there is actually even a prosthetic device you can have inserted to basically recreate erections that works really well. So, yeah, I mean, in terms of treatment, it is not a death sentence to your sexual activity by any stretch of the imagination.
Addie, I don't want to keep ignoring you sitting over there. You look so peaceful.
Yeah.
Is there a difference between BPH and prostate cancer?
Absolutely. And the word cancer is the difference, but we don't know because oftentimes we will have a person come in with an elevated PSA and it'll be really bad BPH, or it'll be urinary issues with BPH. And so that's the time when you need to meet with your doctor and get an exam, as well as speak with one of these people about whether that needs to be evaluated. And what is evaluation? It's if there is a mass found on an ultrasound, which is done over the actual gland, then biopsies are taken to either prove or disprove that that's a cancer. So very different things. One is benign, one is potentially dangerous.
She brings up imaging.
Yeah.
Do one of you want to go down that road and help us out?
So one of the latest advents, I would say probably in the last 10 years-ish, was this idea of using MRI to guide prostate cancer screening. It has been a way to try to determine who in the list has BPH and who in the list has prostate cancer. There's a variety of ways. It basically looks at, very simply, prostate is mostly water, and then if you have a lot of cells in one place, that generally tends to be cancerous, and so that's the reason why that area lights up on the MRI, and that's the area we direct our biopsies into. And that has improved a lot. It used to be basically anybody who's had an elevated PSA, you got a biopsy, and now we can actually stratify them into, okay, you have an elevated PSA, but it's just because your prostate's 200 grams, or now you have an elevated PSA, but it's actually because you have this spot in here that's very likely cancerous.
Is that prostate biopsy an office procedure, or do you do it in the hospital?
I do most of my prostate biopsies in the office.
As do I.
I think that they're fairly well tolerated. And certainly if anybody's very uncomfortable, we would just stop and we can always schedule it for something to be done under anesthesia. There's a different type of prostate biopsy called a transperineal biopsy, where you go through the skin underneath the scrotum. That tends to be a little bit more uncomfortable. Those patients usually do get sedated for that procedure.
As long as we're chatting here, are there any new medications? We've kind of been through this, but just to finish it off, are there any new medications or advancements in treating prostate cancer? And I think we've finished that, but there are some things sitting on the horizon too, aren't there?
The biggest thing that we've learned was the idea that prostate cancer makes its own testosterone. It used to be we would, in late stage prostate cancer, we'd assume that, we had this thing that turned off testosterone, and testosterone is basically food for prostate cancer. And so we'd give them that, and then that would quit working, and we assumed that it learned to grow without testosterone. But actually, what had happened was that the prostate cancer learned to build its own testosterone. And then we learned ways for the testosterone to be blockaded at the prostate cancer cell level. And that was probably the biggest advance in terms of medications, at least, and also just the idea that chemo could work. We used to assume that chemo could not work for late-stage prostate cancer, and now there is chemo for it, which there wasn't before. So both those things have, it used to be you had metastatic prostate cancer, you had a year left, go to the beach and have a good time because that's all you got. And now I got people 5, 10, 15 years on these medicines that are doing fine.
Or they're dying of their other cancers.
Right, exactly.
I mean,
Are there other problems?
Yeah. I mean, I think that has been a huge shift, especially in the last 8 years that I've been in practice, is more use of chemotherapy and all these different androgen receptors that we're being able to interfere with actually pretty good tolerance, and patients are living a lot longer than they used to.
Did you want to jump in?
Well, I think oncology care in general has advanced just because of the development of antibodies to use as chemotherapy instead of just cell-killing drugs that we give people.
Very
so
true.
there's a lot of truth to be told about oncology advancing dramatically over the past 15 years.
Across medicine,
Yes,
Yeah.
it's
there's
amazing.
been a lot.
Teaching the immune system to kill it rather than us having to kill it has been a huge step forward.
Amazing.
Can you take Flomax and Viagra together?
I say yes. I would say that
As do I.
if you're a patient that tends to have low blood pressure at baseline, then I would say take them 12 hours apart. I think is what my usual recommendation is. But most of my patients do not suffer from low blood pressure, and I think it's fairly safe to take both at the same time. Now, you should never take your nitroglycerin and your Viagra together.
Yep. That's the only absolute contraindication.
You should not do that.
If you've taken Viagra and you have chest pain and you have nitroglycerin in your pocket, you have to go to the ER and your first words out of your mouth have to be, I have chest pain and I've taken Viagra, because they'll give you nitroglycerin there too and it's still bad.
Addie, what are the benefits of saw palmetto? Does it help with ED?
That one I don't know the exact.
We don't think it helps with ED. It's a version of a drug that we give, the finasteride you already mentioned. It's basically a testosterone. There's a more potent testosterone that makes your prostate grow, and so when you take testosterone, when you have testosterone and it gets converted in this more potent form, your prostate gets bigger. Saw palmetto blocks that conversion. With the finasteride that she mentioned earlier is the other way to do it medically. And all the other ones that you see, the super beta prostate, those are other versions thereof of what are called the plant sterols, the medicines that the herbs that block that conversion process.
I would say the studies are pretty mixed on how much it helps with voiding symptoms with saw palmetto. I think it's certainly reasonable to try if patients want to try something before they see the urologist.
Yep.
But the studies have not consistently shown that it's that beneficial, that our medications actually work better.
Correct. And the other issue is the fact that those are fairly unregulated in terms of what they actually get. And so, like, they did this study one time where if you got the I forget, I don't want to poo-poo any specific store, but one store saw palmetto was like 99% saw palmetto, and the other stores was like 2%. And so those studies, which all have to be done in that fashion, you just don't know what you're getting.
This is an adult male with surgery for an undescended testicle as a child. Will this have any effects on fertility or other long-term issues? And go ahead.
Yeah, that patients that have had an undescended testicle and have had surgery are at higher risk for fertility issues. That testicle sometimes is not very good, depending on when when that surgery was performed. If it was done as a child, it has a chance of being successful, of producing testosterone and sperm, but there's a chance that it might not be as fertile as the other testicle, as a normal testicle, especially depending on the age that was performed. It also is those patients also have an increased risk for testicular cancer, and so they should be screening themselves with self-exams where if they have that history of an undescended testicle.
And wear a cup.
And protection, always wear protection.
Yep, protect the remaining boy.
Yes.
So we've been dancing around testosterone, the fountain of youth. So there's a lot of this going on out in the public now. There's a lot of discussion about it. Advice.
Well, I think the
Yes.
people
Come
who
on,
come
family.
in to see me to talk about testosterone always say, I want it checked. It's got to be the cause of my fatigue, of my lack of ability to get an erection, of numerous things that are very common and that are very much associated with other more common things like obesity, like smoking, like other medications they take, diabetes, alcohol use, drug use, or depression, mental health issues. So when someone comes to my office, am I willing to check a testosterone if they want it? Yes, but by and far, I can tell you most people are going to have a fairly normal level when we do check. When we do see an abnormally low testosterone, especially in a younger person, that's a reason for me to refer to my colleagues.
Yeah, and in general, I can say that in the number of, I do see a fair amount of low testosterone. There's a lot of argument as of what a quote-unquote normal testosterone really is, because you would assume that the testosterone of a 20-year-old should be different than the testosterone of a 70-year-old. But even using that, there's a paper that came out about the age-adjusted testosterone. Even using that, and you replace them to that age-adjusted level, not everybody feels better. Testosterone is not the elixir of life. It's one part of a much larger health picture than just this one value.
Rebecca, we're getting down in time,
Okay.
but the question is kind of floating around Peyronie's disease. Is there any cure or procedure for Peyronie's disease? Maybe tell us what it is a little bit too.
So Peyronie's disease is
We have 1 minute.
is angulation of the testicle or the penis when you have an erection. So sometimes it's Usually it's painful when it's just starting. We don't always know why it happened. Treatment really just depends on how symptomatic you are. If you have some curvature to your penis and you're still able to have intercourse the way you want to, then we leave it alone. But if patients are having pain with penetration or can't have penetrative intercourse and that is what their goal is, then there is lots of treatment options out there, including injections, medications to help improve erections, penile prosthesis or other surgeries to help straighten the erections. None of them are perfect. It's a conversation that really just depends on the degree of bother and the goals.
Real quick question, LUTS, what does that stand for?
Lower urinary tract symptoms. So meaning how your bladder functions, how your urine gets outside your body.
I want to thank our panelists, Dr. Rebecca Beach, Dr. Nathan Hoffman, and Dr. Addie Vittorio, and our medical student volunteers, Riley Berg, Alex Higgins, and Wyatt Windhorst. Next week, join Mary Morehouse for a program on mental health focusing on anxiety and its effects. Thank you so much for watching. Have a great night. And panel, thank you.